earlier also we have had similar sessions with you all, and it was never enough. So definitely thanking you both for that wonderful session. Next we have Prathima Madam itself speaking on evolving anomalies in the third trimester. Definitely it is a cause of concern because most of the patients, as far as we are concerned in the obstetric units, they feel the anomaly scan is done, it is normal, then there is no cause of concern other than probably FGR. But about late onset anomalies, that is yet another topic to be discussed and it has to come up. Madam, over to you.
How much time do I have? Not 8 minutes, I hope.
25 minutes, madam. 25 minutes.
It says 8 minutes here, so.
That was for the discussion, ma'am, of the previous dialogue. Yeah.
Fine, not a problem. Thank you so much. And okay, so we've been talking a lot about first trimester, second trimester, and we know that ultrasound is really the fist of the obstetrician, I would say, to be able to see the baby much better. And over a period of time, we have seen that what was being detected in the third trimester is now being detected in the second trimester. Second trimester anomalies are being detected in the first trimester. And of course, a large number of anomalies that are being detected in the first trimester, a few in the second, and a few more in the third trimester. And don't forget that some of them will be missed. There are postnatal detection of anomalies as well. Now, the challenges with a third trimester scan is that it is not routine to look at third trimester anomalies in the third trimester. We just look at the growth, we look at the measurements, and it's considered to be a low yield. That means the chances of finding an abnormality is very low. There are no national, international guidelines, there are no protocols, there are no screening studies, and typically, disclaimers we see, this is not an anomaly scan or this is not for medico-legal purpose, but we know none of these things hold true. When it goes to the court of law, you still have to go through the entire circus, irrespective of whatever you have written in your disclaimers, okay? So, let us see what is the evidence for detection of anomalies in the third trimester. Now, there are a few studies which have looked at detection of anomalies in the third trimester, and this is one of the studies way back in 2011, where overall anomalies were about nearly 4%, and 40% detection in the first trimester, 35 in the second. When new anomalies were detected in the third trimester was about 15%. I mean, I'm talking about 11 years ago, and primarily in the urinary tract, the heart, the gastrointestinal, and the brain, of course. This was a study that we had done in 2010, where we found about 2% anomalies in the third trimester after having done good first trimester and second trimester scans. This was from Kypros's group, where they had again a few anomalies that were detected in the third trimester and in the postnatal. Now, this is a study by Drucker, which is actually a meta-analysis of 13.
Sorry, the slide is not changing.
Oh.
This is the first slide.
I've gone way ahead. Sorry, I did not see that at all. My apologies. I think we can start from here, isn't it? All right. Right, so 13 studies, systematic review, and about 3.68 per 1,000 women, and primarily urogenital, CNS, and cardia. Now, this is a forest plot of the same thing, which looked at the studies and saw that there are, some studies have shown a benefit in doing the third trimester scan. Sorry. What was different in these studies was that some of the studies were focused to find an anomaly, and some of them were focused only to do the growth scan, right? So the intention of the third trimester scan was to, in addition to check the growth, look at the abnormalities also. And of course, when you set the intention right, the chances of picking up an abnormality also will be higher. Like anything else in life, if your intention is right, you're more likely to achieve the goal than if your intention was something else, right? So the 1 in 300, there was an incidental anomaly, as they said. And what was important is to inform the parents that when they're going for a growth scan, that there is a chances of picking up an abnormality also. Now, we looked into our data recently for one of the conferences, and in the third trimester scan, and we looked for the evolving structural fetal anomalies. And this was primarily to assess the abnormalities which were detected between 28 and 40 weeks in our setup, and of course, come up with a recommended set of planes that we must examine in all pregnancies, all scans which are performed in the third trimester. This is a retrospective single center study, and we grouped them into 28 to 32 weeks, 33 to 36 weeks, and 37 to 40 weeks. And this was just basically, people who came for anomaly scans, that's it. And we excluded the multiple pregnancies. So about 27,000, nearly 28,000 pregnancies, scans in the third trimester. And there were about 5.8% anomalies were detected, of which 34%, that is 1/3, were previously detected. So new anomalies, the first time we have detected, was about 65%. And then we divided them into ones which could have been possibly detected if they had done a proper anomaly scan, and versus truly evolving. So 1 in 4 anomalies that were detected in the third trimester could have been picked up much earlier. So they were either not picked up or missed, or the mother herself would have missed the scan at that point of time, right? Because we do have these scenarios as well. So the truly evolving anomalies accounted to about 2.8%, 3% roughly, okay? So that's the same breakup, and according to the gestational age. So the earlier, they were more, the truly evolving were more common in the 28 to 32 weeks, about 60%, and 30% in the 33 to 36 weeks, okay? And largely, they were gastrointestinal, the genitourinary, brain abnormalities, and cardiac abnormalities that were picked up. And now I'm talking about truly evolving anomalies, right, in the third trimester. Right, so the same thing we'll go through, and most common in the central nervous system was ventriculomegaly, abdominal cyst in the GI system, and hydronephrosis in the genitourinary symptoms. Now, the conclusions of this study was about 3% of evolving anomalies present for the first time in the pregnancy beyond 28 weeks, and therefore third trimester scan has the potential to detect evolving anomalies, and it is very important to have appropriate planes to detect these anomalies, and of course help them to evaluate and manage and prepare for place for delivery and postnatal investigations, and this would potentially lead to much better outcomes in the pregnancy. Now, why do abnormalities evolve? Now, there are two reasons. One is because the organ itself has the abnormality, but because it becomes bigger, you are able to see much better thanks to the resolution of the ultrasound. Or the other possibility is there could be an external insult because of which there can be like a hemorrhage. But sometimes the abnormal gene may be activated later on in the pregnancy, and therefore you see only later on in the pregnancy. And we'll just go through a few examples there. So central nervous system, as I told you, ventriculomegaly was the most common. It could be related to chromosomal abnormalities, genetic abnormalities, infection, and hemorrhage as well. So it is very important when you see ventriculomegaly in the third trimester to go back and see what is the kind of screening that she has had, right? If she has had no screening, or even if she has had screening, you have to still think about possibility of chromosomal and genetic abnormalities, because many of the developing brain abnormalities can present as ventriculomegaly as a first marker. Now, these are a couple of examples of, and here you can see calcifications there as well, in addition to in addition to ventriculomegaly. This one was referred to as ventriculomegaly, but when we saw the calcifications, there could be indication of an infection, or there are certain other genetic conditions where you can have they can present what they call as a pseudotoxoplasmosis kind of a scenario, where you can have genetic abnormalities with intracranial calcifications. Now, intracranial hemorrhage again can present for the first time in the third trimester because of many reasons, and and that could be the if you don't look for it carefully, you may not see it, right? Again, micro and megalencephaly are again evolving abnormalities seen in the third trimester, or late second trimester, or even the third trimester. Now, some examples in the genitourinary, the most common is hydronephrosis, the renal, and they can have multicystic dysplastic kidneys, echogenic kidneys in the third trimester as well, apart from sometimes the some posterurethral valves will present much later on as well, and we have seen that even 28 to 30 weeks partial posterurethral valves kind of a picture there, right? So those probably will respond much better to treatment, provided one, we pick them up, two is we institute postnatal management appropriately for them before any infections and other problems set up. Gastrointestinal, the most common is abdominal cyst, and again gonadal cyst being the most common. This was at 36 weeks, and you can see large, right next to the bladder, you can see a big cyst there, right? Now this is a gut valvulus. This was a very interesting case where they had a previous history of a baby that was born with fetal anemia and then gut volvulus. And in this pregnancy, there was fetal anemia at 32 weeks. And then when we were scanning, and there was increased amniotic fluid, as you can see. And when we saw when we were scanning the abdomen, you could see this kind of homogeneous mass there, which looked like a gut volvulus. So there was a recurrence of the condition as well. So this fetus, of course, underwent genetic testing as well because there was a recurrence. But this one, because it was picked up early, this kid actually did better than the previous one. The previous one they lost because the diagnosis also was late. Then bowel obstructions very typically occur in the third trimester, and these are they are picked up. So, and if they are picked up in the third trimester, they will actually be delivered in a surgical unit and have much better outcomes as well. Tracheoesophageal fistula, as well, increased amniotic fluid, absent stomach bubble, and again typically from 26 weeks onwards they start increasing the amniotic fluid because that's when the urine production increases. But sometimes you can see a stomach bubble also because some forms of tracheoesophageal fistula you may not have that significant increase in the amniotic fluid, and a small stomach bubble could still be visible. So depending upon how severe the fistula is, you will have varying presentations. Then calcifications, which could be a marker for growth restriction, which could be marker of chromosomal and genetic abnormalities as well. In the cardiovascular system, ventricular septal defect, particularly the small ones, are probably picked up in the third trimester, and coarctation of aorta, again a typical third trimester diagnosis, which can be, of course, there are a lot of false positives and false negatives as well. This was an interesting case where there was a unprovoked, I would say, because there was no history to indicate that, there was a premature closure of the foramen ovale. These are the postnatal images of the same baby, right? Rhabdomyomas can present late, particularly the ones which are associated, not associated with tuberous sclerosis. The tuberous sclerosis are the ones which come much early, but rhabdomyomas, again, tumors, any tumor in any part of the body is a third trimester diagnosis. Skeletal system, typically achondroplasia and focal femoral hypoplasia. Non-lethal skeletal dysplasias are third trimester findings, right? In the thorax, diaphragmatic hernia, very commonly seen in the third trimester. And of course, if we choose where we are going to deliver these babies will actually do much better because they need to be ventilated at birth and managed by the surgical team, and they will actually do much better if they are diagnosed prenatally rather than allowed to compromise after birth. Okay? So bilateral pleural effusion can sometimes occur for the first time in the third trimester. Simple thing is to drain the fluid, allow the baby to get maturity, allow the lungs to expand, and then deliver the baby at term is far better than just delivering at the detection of bilateral pleural effusion. It's very simple, just put in a needle and drain that fluid out, allow the baby some more in utero healing, and then deliver. I think here I would very much like to emphasize that there is a tendency for obstetricians to panic and deliver every baby premature. But remember, these babies are to some extent compromised. If you're delivering a compromised baby at 34 weeks, it is not going to have the same outcome as an uncompromised spontaneous delivery at 34 weeks. They are not the same. A compromised baby will do far worse. Like an anemic baby will do a far worse at 34 weeks than a normal 34-weeker spontaneous delivery. So it is very important to correct the problem or to reduce the problem and then deliver the baby so that the baby will have much better outcome, because we don't want to add insult to injury, right? So compromised babies need more time in utero to heal as well, right? So coming to the face and neck, again, micrognathia can sometimes, unfortunately, the more severe micrognathias which are associated with certain genetic syndromes also can present late because it's the growth of the facial bones which can cause the problem. Thyroid, fetal goiter, neck masses, lymphangiomas again, tumors, oral tumor, this was an oral tumor, can present in the third trimester. Hydrops, tumors, cysts, all of them can happen in the third trimester. Sacrococcygeal teratoma can become very obvious in the third trimester. It can be very small in the second trimester. So coming to what is the best planes? What are the scan that we must do? Are we adding on more planes in the third trimester, or can we do with what we are doing? Well, pretty much we are seeing all these things on the scan anyway. We are using all these planes anyway. We are doing transventricular, transcerebellar plane to measure the BPD HCAC. We look at the face, we like to show the face to the parents. We look at the 4 chambers anyway to look at the viability. Just come a little bit up and look at the 3 vessel also, so that you know that there is no discrepancy in the chambers. Anyway, you're going to measure the AC in the abdominal view, and you're looking at the kidneys and bladder, which are some of the most common anomalies seen in the third trimester, and you're going to measure the femur length. So pretty much everything you will get in all these views. All the abnormalities I described, you will suspect in these views. And so there is nothing additionally or something rocket science that you need to do, apart from these 2 views that I really like, the 4 chamber, looking at the crux, making sure that's okay, and 3 vessel view. And for this, you don't need the baby in a perfect position. Somebody who's used to doing third trimester scans can create can easily get an axial view of the chest and get these views, and the same applies to the kidneys and the bladder. So pretty much you can get everything. So now what happens if you find an abnormality in the third trimester? Now it is very important, when you find an abnormality, you identify the system, right, or the systems that is involved. You go back and take a detailed history, because there could be something relevant, because we do have a big consanguineous and big genetic pool, abnormal genetic pool in our, in our communities. So we take a detailed history, look at the consanguinity, take a good obstetric history. It's very, very important to review the previous scans, the first trimester and the second trimester scan, to check whether it has been reported before or it has not been reported before. And if it has not been reported before, could it be potentially detectable, or is it truly evolving? Now, when it comes to truly evolving anomalies, we have to check whether we need to then, many times we have to involve specialists from other fields, like a neurologist or a neurosurgeon, or for a vein of Galen malformation or a arachnoid cyst, you may need a neurosurgeon. For a GI abnormality or GU abnormality, you will need a pediatric surgeon or a pediatric urologist. And of course, where are we going to deliver this baby? The place, the mode of delivery. Is the abnormality going to get worse by doing a vaginal delivery, or we can still go ahead with a vaginal delivery? Because many of these other specialty will still say, there is no need for there's no reason to do a cesarean section. We could still go ahead with a vaginal delivery. And of course, it has to be multidisciplinary, taking into confidence all the, allied specialties and the parents, of course, if you're really wanting to aim for better outcomes for the baby. And finally, we should not presume that even a sick baby will be alive at the end of 24 or 48 hours. We need to take the blood, store the DNA, and then we have to get to a logical conclusion, because at the end of the day, when abnormalities are detected in the third trimester, the risk of recurrence is extremely important, because even in the subsequent pregnancies, you will still have it only in the third trimester. You may not be able to detect in the first trimester. So reaching a logical conclusion as to why this abnormality happened is extremely, extremely important. So there are lessons that we are learning. I would not say lessons learned. It is never learned. We are learning. We need to assess the growth. We need to assess the fetal well-being, and well-being can be assessed only once we have checked for any developing abnormalities, and of course plan the delivery. We need to inform the parents before they go ahead for the third trimester scan as much as possible, to say that there is a possibility that an abnormality that was not detected before can be detected in this scan. And of course, the growth scan must entail looking at structures, right, which is already there. I didn't show any extra views, to be very honest. We need to evaluate what it is, we need to document it, and of course, post the scan, we need to assess what is the possibility of it happening again. Thank you very much.
Thank you so much, Dr. Prathima. Actually, I think that is something which is a big dilemma for the practicing obstetrician. If we have anomalies detected in the third trimester, a lot of questions to be answered. But does that mean that probably we should go for fetal medicine scanning every time? But probably that doesn't change the picture, does it?
No, I think anyway
Because
we
you said 25% is detected if we do a proper scan in the second trimester still.
Well, ideally, yes, 25% were detected in the ones that was there. 1 in 4 could have been detected, but there are reasons why it was not detected. That is a separate issue that needs to be addressed, right? Because where the scan was done, who did the scan, did the patient go at the right time, was it detected but not reported? So there are so many issues there, right? So that is not, the thing is what I'm trying to address here is when we are doing a third trimester scan, it is not enough at all to just do the BPD, HC, AC, FL and then say, okay, now this baby is normally grown, so just, this is not an anomaly scan, this is not for medical legal purpose. It's not going to cover. If you've seen the AC, you've seen the stomach bubble, you've seen the gallbladder, you've seen the portal vein, because that's where you need to see the AC measurement. So it's there in front of your eyes, right? You're checking the viability, you're checking the baby is alive. That 4 chambers is right in front of your eyes, right? So you need to be training your eyes to be able to pick up anomalies even in the third trimester. To me, every scan is an anomaly scan, whether it is whichever trimester it is, right? At one level, we are talking about anomalies being picked up at 8, 9, 10 weeks. But a large majority of our scans are being performed after 26, 28 weeks. So we should not ignore the anomalies there. Many of them will be truly evolving, but some of them will be potentially detectable also.
Now, what are the anomalies in where you can have a fetal intervention antenatally? Is there any place for a fetal intervention at that point of time, the third trimester?
Yeah, I mean, first of all, I think even if you detect anomaly in the third trimester, for example, ventriculomegaly, for example, right? I think it is important to, one, do a diagnostic investigation. Very important. Diagnostic to check for chromosomes, genetic, it's very, very important, because if there is a genetic abnormality in this baby, the question comes, are you going to deliver this baby by cesarean section, right, or not? Second question is, there is now medical board in every state, in every place, the government medical colleges have, and if there is a significant anomaly that is going to cause a lot of morbidity to the baby and to the mother, you can apply to them for legal termination of pregnancy. And I think we must use this post 24 weeks. We are allowed termination of pregnancy provided we prove that this is going to be really bad for the baby and the mother. Then third very important point is, for example, pleural effusion. If there is bilateral pleural effusion and the baby is chromosomally normal, once I have proven that, I can put a shunt and pull this baby to 38 weeks and then deliver the baby at 38 weeks, which will give the baby far better outcome. Even pleural effusion at 34 weeks, I will drain the fluid out, give the baby some time in utero. I may not put a shunt at 34 weeks, but I will drain the fluid out, let the lungs expand, and deliver the baby at 38 weeks. Why do you want to get the baby born with a compromised lungs, right? What I'm again emphasizing is that delivering a spontaneous delivery at 34 weeks in a normal pregnancy, a 2.2 kilo baby versus a 2.1 kilo baby with pleural effusion are two very different things, right? That baby, the baby with the anomaly is compromised more. For that, prematurity will be adding insult to injury. So we need to be able to distinguish that, and we need to give the fetal therapy a free hand there to be able to diagnosis also and therapy also, both. Late diagnosis must be done.
Thank you so much, ma'am. That was a very, excellent and very practical sort of thing. Yeah, thank you so much.
Thank you so much. Thank you very much, everybody.